my name is Dr. James Thomas. I'm Senior Consultant Interventional Cardiologist at Mass Liva Medicity, Pala, Kerala. So I'm talking about the use of troponin or persistently elevated troponin in heart failure. Now we have all been using troponin in coronary artery disease and acute coronary syndrome. And the first data of having elevated troponin in heart failure actually came long back in 1996. So since then people have been trying to utilize troponin for prognosticating the outcome of patients in heart failure. Now if you see the data, you can see that the prevalence of elevated troponin varies from as low as 10% to as high as 90%. It depends upon multiple factors. One is the population in whom you are studying. That is, if you have a lot of ischemic subset, then of course your troponin will be high. Or the cutoffs you use. If you use a low cutoff, of course the prevalence will increase. But the most important thing is the method with which you are assaying troponin. For example, in the VALHEF study, it was seen that if you use the usual troponin or the conventional troponin, it is elevated in around 10%. But if you assay it by high sensitivity troponin, the prevalence actually goes up to as high as 90%. So that is one point. Second thing is, what does an elevated troponin mean? An elevated troponin has been consistently associated with bad outcomes in heart failure, be that mortality, hospitalization, or the transplant numbers. And even more important is how your troponin behaves over time. Suppose if someone is having a troponin which is remaining stable, or someone which is having a troponin which is decreasing, or someone which is in whom the troponin is increasing. Whenever the troponin is having an increasing trend, that puts the patient at a higher risk. And when someone is having a decreasing troponin, of course the risk comes down. So basically troponin or the elevated troponin in heart failure, it is basically they are used to prognosticate patients. It is slightly different from how you use BNP, because BNP we can use it as an indicator whether your therapy is working or not. For example, you can tailor your diuretics based upon BNP, but troponin is not for that. You can't tailor your diuretics, you can't alter your treatment based upon troponin. Basically, you can prognosticate patients. And also one more thing is, it is not like in ACS. In ACS you have a cutoff. In heart failure, it is more of a continuum. So we have to see, if you are using it, we have to see it on a continuum.